Welcome, doctors. I got a really incredible program today for you. The importance of CRMA spinal ligament testing from a successful plaintiff attorney's point of view. I got an incredible guest on our webinars. A lot of you doctors tune in to our webinars on a regular basis to understand more about computerized radiographic mensuration analysis. My name is Dr. Cronk. I'm with Spinal Kinetics. One of the things that I want to talk about, I'm going to give a little bit of a short intro into Spinal Kinetics before we get started with our guest plaintiff attorney today, is that Spinal Kinetics has a trademark term called CRMA, which is computerized radiographic mensuration analysis, which is essentially intersegmental motion testing for ligament damage. Now, the reason why we trademarked our term, and we're going to be policing our trademark, is that we do not want to be associated with softwares such as DXD, DRMA, Posturate. Not saying anything negative about them. However, what we are saying is that our process is completely different, and we're trying to elevate the professionalism and the utilization of these findings. And so what makes us uniquely different from anything in the market is that all of our studies, if we have a ratable study, which is a significant severe ligament damage study, they're usually reviewed by 3 licensed professionals. So in other words, in our company, we don't care what the findings are. So we're an unbiased third party. That's what makes us significant in the market today. We're unbiased, and we have a quality assurance program. In other words, we're the only company in the market that has 2 or 3 licensed professionals reviewing the results for accuracy, so that when we put out a report, those reports are completely as accurate as they can be, error-free. We know that when you're dealing with injuries, the #1 thing you got to get right is the diagnosis. The diagnosis of the injury is key. It's primary. There's not a personal injury attorney in the market today that wouldn't agree with that. You have to determine the severity and location of the injury. Injury's severity and location are determined by the actual derangement of a body part. It's impossible to injure a body without deranging the part. So we know that we have these imaging biomarkers. An imaging biomarker is a feature in an image that leads to the definite diagnosis of the condition. So today, it's really easy. I have up for you a fracture. You couldn't determine the severity and location of a fracture without actually looking at the deranged body part. It's impossible. Now, there's a difference. There's a big difference between that fracture that you see right there and a hairline fracture. So how you determine the severity of, say, this fracture right here is determined by the amount of derangement, the measured derangement of that body part. This is very important to understand, because today in the spinal injury market, there are 3 very significant bioimaging markers, or imaging biomarkers, excuse me. And the majority of the market focuses on 2 of them. And that's caused a great deal of problems from our side, and with our company, it's caused the largest epidemic of chronic pain, because the other imaging biomarker is not fully understood, and it's the most significant ligament injury that there is. So what are they? Well, first, a spinal fracture is an imaging biomarker. And as long as that fracture does not damage soft tissue, it's not a serious injury. It's when it damages soft tissue that the injury becomes significant. Now, no one really has much trouble if the patient shows up, they're in a car accident, they got hurt at work, and they broke their back, they broke their neck. That's not the typical patient that we're dealing with at Spinal Kinetics. The typical patient is that there's not a fracture, but there is a ligament injury. So when it comes to ligament injuries, there are 2 very significant imaging biomarkers, and they're extremely important. Quick overview: spine, 100 intricate joints, 220 specialized ligaments, only 23 of which are discs. So if we look at here's the disc, which is a ligament, 9 other supporting ligaments around that disc. Now, there's been an overemphasis on one of the imaging biomarkers, which is called a disc herniation. And a disc herniation is picked up on an MRI, but it's not, it's a fantastic procedure. It's a fantastic imaging procedure, but it cannot pick up the other imaging biomarker, which is excessive motion in the spine itself. So again, this is just a quick synopsis. When spinal ligament injuries are damaged, excessive motion in rotation, which is here, or translation occur and is easily measured by board-certified medical radiologists. The higher the levels of excessive motion indicated, the more damage indicated. Just like you saw that fracture, the farther the separation of bone is, the worse the fracture is. The more the excessive motion is here, the worse the ligament damage is to the spine. And the ligament damage is easily damaged in compressive or shear force conditions or environments. Car accidents, slip and falls, lifting at work, sports injuries. Now, the injury itself, the fracture that I just showed you, if that fracture occurs in an auto accident, it's called an auto injury. If it occurs at work, it's called a work-related injury. If it occurs in sports, it's called a sports-related injury. The injury is the same. It's the same. It's no different with spinal ligament injuries. These can occur from auto injuries. They can occur from work-related injuries, sports-related injuries. It doesn't matter the force or the delivery system or where it was delivered. The injuries are the same. We also know that we have disc herniation. So these are the two imaging biomarkers for soft tissue injuries to the spine: excessive motion and disc herniation. Excessive motion is picked up on X-ray. It's not picked up on MRI, not routinely. Some of the purists out there might say that the weight-bearing MRIs are supposed to be able to pick it up, but nobody does excessive motion studies on the weight-bearing. So it's picked up on X-ray. And this is also your primary imaging procedure. This is the imaging procedure that the patient should have right away. So we also know that these are accurately measured, and they're best measured by an outside, independent, unbiased source because of the significance that they can have in the market. So I'll tell you, I'll go more on that in just a second. This cannot be picked up on MRI. Disc herniations cannot be picked up on X-ray, although X-ray today will tell you with a very high probability whether or not you have disc herniations or not. And that's new research, not for today's webinar, but that's the doctors that really understand ligament injuries know that their excessive motion testing gives them a really good insight as to whether their client or patient has disc herniations or not. So excessive motion testing used properly minimizes the utilization need of advanced imaging procedures. So this idea of everyone needs an MRI is completely false. Not everyone needs an MRI. The doctor needs to be able to differentiate. And again, I'm not running down MRI at all. Ligament injury causes excessive motion. This is a prerequisite for a surgical procedure in healthcare. So if a person were going to have a spinal fusion surgery due to excessive motion, they have to have these parameters before the insurer will say, yes, it's pre-authorized, we're going to pay for it. Now, this surgical procedure right here is much more invasive and a much more serious surgical procedure than a disc herniation with a microdiscectomy is. So remember, I said there's two imaging biomarkers: excessive motion, which picks up excessive motion. If you're going to just do MRI, you only got 23 discs you're really doing an MRI on, but you got 220 specialized ligaments. So this excessive motion testing does testing that incorporates all of the ligaments, not just the disc, because we know that we can have a disc herniation, but a disc herniation, anytime that you have a disc herniation, the first thing that should go on in the minds of the doctor that's trying to figure out how severely damaged is this disc is, are the supporting ligaments around the disc damaged as well? In other words, is there excessive motion at, above, or below the level of the disc herniation? Because if there is, it's a much different herniation. However, in a disc herniation itself, it's a microdiscectomy. I'd much rather have a microdiscectomy than I would a spinal fusion surgery. So all I'm trying to show you here today, doctors, very quickly, is excessive motion shows a more significant ligament injury. We're not going to get into the AMA guides today. The AMA guides have said excessive motion is more problematic than disc herniations. So we know today that both of these create permanent injuries and they need to be picked up. And we can have both, exactly what I said. We can have a disc herniation that has both excessive motion and disc herniation. This is the most significant without damaging the cord. I mean, obviously, if something damaged the cord, that would make it even more significant. The derangement would be more invasive. But shy of damaging the cord, this is the most significant ligament injury you can have in the axial spine. And the problem with patients that have it, remember, 50% of patients today are not going to fully recover, and 30% are going to be quite, 30% of the 50% that don't fully recover are going to be quite debilitated in their future, in their current and future. In other words, it's debilitating their ability to have high quality of life. So that's what disc herniation with no excessive motion completely rehabs differently. So now you're aware of all three of the imaging biomarkers. You're aware of the fact that Spinal Kinetics is a company that uses board certified medical radiologists, is independent in the actual application and measurement. In other words, we don't care what the results are. That's what makes us so valuable to the providers. Providers that are trying to do these studies themselves are looked upon as biased. You're looked upon as biased. And we even have reports that providers are not even doing their own reports with some of these softwares. They're hiring people off the street. The $10, $12 an hour person is actually doing a study in a doctor's office. That's why we're not associated with any of these products themselves. We want to be completely unique in the market. Now, doctor actually gets the study, looks, says, okay, knows the nerve, tests the nerve, has spinal instability, and can now clinically correlate exactly why the patient has the problem they have, and can now be completely guideline driven in their approach. We help doctors to make personal injury, work comp, or patient injury diagnosis primarily extremely easy, and we help providers to easily navigate the medical legal system, because in the medical legal system, the doctor is going to interface now with plaintiff attorneys, defense attorneys, insurance. And so one of the biggest issues that comes up for us is my attorney doesn't understand this. I'm working with attorneys and they don't understand this test. So what I wanted to bring on was an attorney that definitely understands this test and has been using it. And now I'd like to introduce Richard Schroeder. He's a Minnesota and Wisconsin accident injury lawyer. You can read his CV here. He graduated cum laude from Hamline University School of Law. He's licensed in Wisconsin, Minnesota, and Georgia. He's handled cases in 16 different states. The one thing that I want you to understand about Richard is that he's a former insurance claims adjuster. So he comes from an insurance claims adjuster side before he ever became a lawyer. So he understands both sides. He's frequently selected to arbitrate insurance disputes. He's an avid motorcyclist. Matter of fact, he's got some great images on that. And the thing that impressed me so much, and I deal with a lot of attorneys, is that he understood it right away and started to apply it. So I'm really, really happy, Richard, to have you on today with me. Can you hear me?
Yes, I can. Thanks, Dr. Kronk.
Yeah, I'm really happy to have you on with me to be able to communicate, because one of the things at Spinal Kinetics we continuously try to do is say, look, our purpose in our company is about helping doctors do a better job with diagnosis so they can get better results with their patients, we interface with the medical legal community nicely because it's objective, and we all have to, whether we want to or not. I mean, it'd be nice just to say, hey, you do a test, you get paid for the test, and then the doctor, there's no medical legal intervention. No one has to have depositions. Nobody has to go to trials. But that's our today. And so patients need good attorneys that understand this. And doctors, before I start this interview, here's what I'm going to tell you. When you have an attorney that understands ligament injuries, I don't care if your patient lives an hour, 2 hours, 3 hours away from them today. It's too easy today, and obviously I'm being more dramatic, but it's too easy today for patients to hook up with attorneys that understand their injuries. And there's not a lot of face-to-face time. So, one of the things I'm going to pitch to you is if you're a Minnesota, you're a Wisconsin doctor, you want to call Richard and get in touch with him and talk to him about representing cases. But Richard, appreciate having you. How did you, the first thing I want to ask you is, how did you get involved, or, how did you start to learn about CRMA and spinal ligament injury testing?
Yeah, the first time that I got involved with it, I want to say it was probably about 5 years ago or so. Had a treating doctor who had had the CRMA on one of my clients, and it was the case was getting ready to go to trial, and it was new for me, and got the information, read up on it, read the report, met with the treating doctor numerous times to understand it, to understand what I needed to do in questioning her at trial, for the jury, as well as to make sure that we could get her testimony and the report in as evidence with the judge. And we were successful with both of those things, and got a great result with the jury. But because of that, the treating doctor knew what the CRMA was, knew how to explain it, brought it down to the average juror's, I guess, education and attention span.
Absolutely.
And they understood it. They were, okay, hey, we get it. And it wasn't just her saying, yeah, this person has, a grade 3 or grade 4, sprain, strain, whatever. It was, no, here's objective proof of what's going on with my patient, my client. So that's the first that I became aware of it. And then after that, I got more information from Spinal Kinetics, and then started talking to my clients' treating docs and saying, we on the folks, of course, that weren't getting better, maybe had a negative MRI, and said, we need to, have this test, and let's see what it shows, and let's see if it can help explain what's going on.
Yep. No, that's absolutely perfect. Now you are now, I'm going to tell you right now, as far as an attorney and understanding it, you have probably as good of understanding of spinal ligament injuries as any attorney that I've worked with, and I've done a lot of work a long time. You understood it right away. It made sense. It's simple, so it's easy to present to jurors. But how important, like right now, how important to you is the objectivity of the injury? And can you kind of speak to a little bit to the understanding now that you have of, wow, we only knew MRI at first, and the success? Yeah, go ahead.
Yeah, I was just going to say, obviously, having something objective, because as we all know, subjective complaints without anything objective to back that up, it turns out to be, he said, she said, she said, she said. And then when you have the insurance company doctor, saying, no, I don't find any problems with range of motion, I don't find any muscle spasms, I don't find any limitations. And then it's, the treating doc saying, well, my record shows that. Well, then it comes down to who's the jury, going to believe, or who's the insurance adjuster going to believe. When you have something objective, that's all the proof in the world. And even, to one of the things in the initial presentation, had a client that had a spinal fracture at, I want to say C4, and in fact, Dr. Kronk, you remember this one because the fracture, of course, healed. She was out of the collar, out of everything. It was, whatever. I think it went on to 8, 10, 12 weeks. Finally healed up. She continued to have significant, cervical spine, pain, and of course kept going back to the orthopedist, who said, well, the fracture's healed. I guess I don't know what else to do. Physical therapy, she had all that. MedX program had all that. The treating, wasn't the treating chiropractor, another chiropractor that I got her to that was aware of spinal kinetics, sent her out for a CRMA. I don't recall what the excessive motion instability was, but it was significant. And then I found out after the fact that you remembered this, Dr. Kronk, because Spinal Kinetics had sent it to you and said kind of something to the effect, there's got to be something wrong here. There's a glitch in the software because there's no way that this could be this excessive. And you guys ran it through a second time, and that's what it came out to.
That's correct. That's correct. And that's Rick. You're speaking now to the quality control in our company, where we're looking at things. We're looking at it, and when we pick up in that case something that is so significant, of course, we're thinking with, is there another fracture here? Is there a dislocation here? Yeah, it was significant.
Yeah, and so I mean, on a variety of levels, it explained, of course, objectively why my client was still having problems, even though the fracture had healed, number one. Number two is it helped her to understand, because she kept being told by the orthopedist that, well, the fracture's healed. I don't know, I don't know what else to do for you. I don't know why you're still having problems. You've had physical therapy, you've had the MedX program. So it helped her understand it. And then from what I would say a medical legal perspective, it helped me in kind of on the eve of trial with the insurance company, to get the case resolved for the policy limits that we were dealing with, because of the fact that we now had objective findings to support what was going on, and it convinced them. Also, at the same time, she had taken it to her family doctor, who said, boy, we should get an orthopedic spine surgeon, neurosurgeon, just a consult to see, do you need surgery? Are you going to need surgery? And ended up with a nice opinion there that she didn't need it, thankfully, at that time, but put in his records that he had reviewed this report with her and then discussed with her, how significant this injury was. So, as well as the family doctor. And I just had a recent client that took the same report to her family doctor and was very interested in it, and was okay, of course, with her still treating with the treating chiropractor, also recommended some MedX treatment, which the treating chiropractor had just recommended as well. So I think the introduction of it in other specialties as well, whether it's primary care physician, neurologist, a PM&R doctor, I'm starting to do that and making sure my clients are taking these reports to these other treating physicians to make sure that they become aware of them as well.
I'm just going to ask you a question, just off the cuff. What do you think the significance, because I know the significance, for me, being a doctor of chiropractic for years in practice, the significance of having it be unbiased and produced by a medical radiologist in a company. When you're taking it out to medical providers or other providers, there's a degree of leverage, because it's not like you're saying, well, look, I measured something myself on the X-ray, and the doctor's looking at it and saying, I don't really know what this is. They're looking at it and saying, okay, I've got a report from a board certified medical radiologist, excessive motion. Even though I may not understand it, there's an air of credibility there that leverages the doctor, so that you can start to leverage these relationships, because patients that are seriously injured, a team approach is often needed. So to me, it makes it easier for the doctors to actually establish the relationships because of the credibility that it brings to the table. And the medical provider can look and say, well, obviously this doctor understands this condition and is safe to be able to be rehabilitating this condition. So yes, I'm going to write a report that says continue with MedX, continue with chiropractic. You know, don't you think, I guess I would ask you, in just the little bit of experience you have with that so far, doesn't that seem like that would be true?
Oh, I mean, clearly having something independent is the key. I guess my analogy would be if I had a client, or if again a doctor's patient that said, well, I can't work doing X anymore. Okay, I mean, we can go with that, but then it's based just on the credibility of that one person. Same if a treating doctor had whatever software and was doing it in their office, well then it's based on just that credibility of that doctor. To me, it's if I have a client that tells me that they can't work doing their trade anymore, or their occupation, I get them set up then with a QRC or a voc rehab person, because then it's not just my client saying that, it's, we've got whatever restrictions from the doctor, but then we have somebody that's in the field of helping people get back to work and finding out, well, what can they do? So it's an independent person. I'm not going to go to trial or go to a hearing with just my client saying, I can't do this anymore. I need something independent. And it's the same thing with the CRMA. It's independent. And I've had some come back that didn't show, instability, but even so, if it showed, some motion, again, if you talked about the guidelines, whether it's the chiropractic guidelines, the Croft guidelines, but if you look at grade 3 under the Croft guidelines for the severity of trauma, it says some ligamentous injury, just some. It doesn't have to be full-blown instability, but I mean that takes it out of then a grade 1 or 2 into a grade 3, and it's not just then the chiropractor saying, well, I think it's a moderate sprain. I think it's I found limited range of motion, where the examining doctor for the insurance company is going to say, I didn't find any limited range of motion, and there's no neurological findings. Even in your records, doctor, you don't have any neurological findings. So no, this isn't a grade 3. We've now bumped it back to a grade 2 or 1, which, as we know, then you start looking, I mean, and again, you can argue those and say those are, garbage and whatever, but at times then you don't even have to do that, because you can then bring it down, or bring it, I guess, up or down, however you want to look at it, in severity to a grade 3. If there is instability, now you're at a grade 4, which then takes it out of, from a recent report I got from a no-fault insurance doctor that said, yep, we all know that most people with, these kinds of grade 1 or 2, injuries, 6 to 12 visits in a 2 to 4 week time frame.
Right.
And that's all this person needed, because right now my client hasn't had the CRMA yet, and that's something she's going to be doing.
Right.
Because I've spoken to her treating chiropractor and said, we're going to need something objective, independent of her notes.
Absolutely. You still there?
What else? Yep.
Okay.
Can you hear me?
Yeah, you cut out just a little bit.
Okay. And if the CRMA in that case, where we just got the insurance exam, said only needs 6 to 12 visits over a 2 to 4 week time frame, if the CRMA doesn't show anything, okay, then we'll fall back. The treating doc will obviously fall back and go, well, okay, what is still causing my patient's ongoing problems?
Right.
There's no herniated disc, there's no fracture, CRMA doesn't show anything. So there is, you know, the arguments of, well, they always show something. I mean, so these tests are biased and whatever. That's not true. It's clearly not true.
Right.
So,
Well, the interesting thing is too is that when you say that to me, I've been around this a long time, and so an insurer could say, hey, look, the auto shop is biased. Every car they see that comes in from an auto accident, they're saying it's damaged. Right? They're not treating
right.
so it's not the normal cars that are coming in. It's damaged cars in the first place.
Yep.
So most patients that are actually injured are damaged, and it's the derangement. Again, it's the derangement of the body part, and you have to have a doctor that understands the derangement of the body part. One question I have, and I just thought about it while you were talking, now that you're really starting to get into this and actually really understanding it, how is it now when you look at files and you go, well, I don't have an MRI, I don't have a CRMA, I don't really have anything. You know, how damaged is the patient? How do you look at that doctor? And it's not, I know and understand that doctors today, a lot of them don't understand completely the best ways to objectify the injuries themselves. But do you start to look at it and say, okay, this is going to be a little more of a challenge?
Well, yeah, yeah, absolutely. They're huge challenges, and those are the types of situations that the insurance industry loves to take those kinds of cases to trial. To, you know, they'll bring in an orthopedist or a neurologist and say, you know, here's our board certified neurologist or orthopedist, and didn't find, you know, all the stuff that we've talked about. No fractures, no herniated discs, no problems with range of motion, et cetera, et cetera. And then you've got the, you know, on the other side, if you have, you know, I'd say just a treating chiropractor without anybody else to back them up, or something objective, an objective test to back up why their opinions differ. I mean, those are almost impossible to try to go to trial and win, at least in Minnesota and Wisconsin. I mean, I subscribe to the jury verdict reporters, and they're tough. And
Right.
even on the other thing too, even on the client matters that I have where there's a herniated disc or a bulging disc, the argument then is, oh, degenerative, pre-existing. You know, the nice thing about a CRMA, it can then, again, hopefully from my perspective, show that, okay, if there is some translation, some excessive motion, some instability in that area, well, that's going to be my argument, and hopefully my client's treating doctor's argument against that, the fact that it's just degenerative. Because if it was just degenerative, then why would we have, you know, following, say, a rear end motor vehicle collision? If it was just degenerative, why would we have then some ligamentous instability injury on top of then, say, a herniated disc or a bulging disc?
Absolutely. Absolutely.
So you've got two independent reports to refute the, oh, it's just degenerative.
Absolutely. And see, in my mind as a doctor, it makes it so easy today to be really specialized in the injury market. In other words, I'm a doctor. I understand the ligament injuries. I do the excessive motion testing. I know I clinically correlate it for a spinal instability. I show the functional loss of the actual deranged body part. It's causing a weakness. It's causing a sensation problem. It's causing a pain problem. I correlate it right to the level, which there's all kinds of, now I've got all the consensus in the world saying, wow, that's one of the best exams. That's by the book. Now I've got the treatment guidelines kicking in that say exactly what I can do. And now I've got the AMA guidelines. If I've got a permanent injury or permanent impairment, they kick in. I got surgical guidelines to show, hey, this is, if somebody doesn't believe this is significant. I got return to play parameters in sports activity to say, hey, look, there's even restrictions in activity if these are significant enough. and now I'm doing my thing. It makes it, but my thing then as the primary doctor, which all doctors should be, is to take that patient and to have them come out of a program in 3 to 6 months, whatever it takes, where they're completely pain-free. They don't have any activity of daily living problems. They don't have any work restrictions, and they're back to their normal life. They've regained the quality of the life that they had before the injury, and that's what I'm specializing in. And I can go out to attorneys and say, look, this is what we do. We're the best at it. And we routinely make it easy for you to deal with the insurance carriers, because you have documentation is the biggest key that's the biggest headache you're going to have, is poor documentation. So it makes it very easy today for doctors to get very specific and to get very good. I've said for years, injured patients should not go to average doctors. It's too high. The 50% of them are not going to fully recover. So we need better doctors. We don't need more doctors. We need better doctors. And that's, that to me, that's our whole thing. That's our whole purpose in spinal kinetics. Rick, I'm going to ask you another question, because this comes up for a lot of the doctors that listen to us. Is that when they go out and they start talking about excessive motion testing, or they go out and start talking about CRMA, which I don't recommend they do. I have a training program that I teach doctors. We recommend that we go out and talk about the actual imaging biomarkers and how they work, and the attorney or the insurer or the public automatically goes, oh wow, this is interesting. But one of the biggest complaints that they have is that the plaintiff attorneys don't understand it. Now, you are an attorney, you're very renowned within your area, you deal with a lot of attorneys. What's your experience with talking to other attorneys about it? Do they get it?
Overall, I would say no, at least at this stage. It's interesting, the ones that I've spoken to about it after, say, whether it's a mediation, an arbitration, a trial, and they wonder, well, how did you get that result? And then I tell them, they're like, oh, never heard of that. Could you, send me some information? What I do is send them a copy of the sample report that Spinal Kinetics provided to me, along with a couple of the brochures. And all of a sudden, what I'm hearing back then is they're going, well, I'm going to have to take a look at, some of my client files and see on the ones where, again, there's no fracture. Maybe they've had an MRI and really didn't show much. Maybe this will help objectively prove why my client is still having the ongoing problems. So,
no, that's perfect.
That's what I've run into. The other thing, Dr. Cronk, you had mentioned about, with MRIs, is that, especially if, say there's just a bulging disc that's effacing the thecal sac. Well, that's, as we know, that's a pain generator. But of course, the insurance company jumps on, well, there's no herniation. Now you've got, excessive motion. You've got some ligamentous injury on top of that. Well, guess what? When that disc then gets irritated, and because of the motion, well, guess what? You're going to have then more times, at least my argument's going to be more times than not, that disc then is going to be affecting or effacing the thecal sac, which is going to be a pain generator. And that's why there's another reason why this person continues to have, ongoing pain, and why they need ongoing treatment. It's not just a treating doctor going, yep, this is what they got. You just have to believe me.
Exactly. And then you cut out just a little bit. So I just want to make sure for the doc, what Rick is saying is that you got a disc bulge, the insurer's contesting it. It definitely is a pain generator. It can be a pain generator, but now you're showing excessive motion. And traditionally, if you're following a standard workup, you already know there's excessive motion because you've already done that procedure. X-rays are your primary thing that you determine a severity and location of a ligament injury with. So in your workup, day 1, day 2, you should have already been taking those X-rays and already assessing where is the excessive motion. But now let's say that you've got a disc, you have need for an MRI, and the MRI comes back and it says disc bulge, right? Well, what Rick is saying is that now that you have the excessive motion, traditionally the insurer says that disc bulge, that's not problematic. Well, now you already have, there's significant excessive motion at that disc bulge level. Of course, that excessive motion is going to further irritate that pain generator. And it's very difficult to say that's not problematic, especially doctors, if you're showing a functional loss at that level. And the greatest example of functional loss is, let's say you're at the C5 nerve level, that disc is impinging on the C5. You have a deltoid test that actually shows weakness. You have a C5 sensory test that shows hyper sensitivity. You have pain showed that is specific to that area. You're saying it, right? But now the patient doesn't actually progress in a manner that you deem necessary. They go out, they have a nerve block at that level, and it shuts everything off. Well, that's the ultimate confirmation of what you said. Now, you're not going to send every patient out to confirm your levels with a nerve block, but I'm just saying that's the ultimate. Doctors that get really good with this will be able to tell the injection specialist exactly what level they should be injecting. That's how good you can get with this, doctors. And that's what personal injury attorneys need. That's what they need. That's what they're looking to work with. So when everybody's going out, how do I attract personal injury attorneys to refer to me? Exactly what I just said. Be extremely good at your job. And then it makes it really, really easy. Your job, accurate diagnosis, catching all these injuries, being able to treat them incredibly well to good results, and being able to document so that the attorneys such as Richard have a really easy time with it. And it becomes very, very easy for them to present. Whether it's, Rick, you have experience with arbitration, court trial experience now with it, and just general settlement with it, correct?
Absolutely.
Yeah. So
absolutely, and even, you know, in the past X number of years now at mediations, I mean, and I've tried to explain this to my colleagues, that where they say, well, you know, how did you get that result for your client? And I go, well, because I had something objective. Oh, well, you must have had MRI that showed, you know, a herniated disc or something. I'm like, nope, I had a CRMA. And I've had the mediators tell me that's what they have used. They have used that report to, for lack of a better term, beat up on the defense attorney and the claims adjusters to, you know, tell them, no, this isn't just your standard, you know, sprain, strain, 4 to 6 weeks, you know, of treatment. You know, this is what you got going on, and this is what I'm going to be objectively showing to the jury and blowing it up or putting it up on the Elmo so that everybody can see, and have my treating doctor explain, what does all this mean for their patient, my client? And it's been a game changer. It clearly has. So, and not only, I mean, obviously for me and my client, but again, for my client's understanding, I've had so many clients recently say, I now understand why I'm still having problems. So when my spouse, boyfriend, girlfriend, coworker, whatever, when they're kind of rolling their eyes and going, well, how come you're not getting better? What's going on? Maybe you should go get a different chiropractor, because my chiropractor got me better in 4 to 6 weeks or 6 visits or whatever. They now have something objective, independent of what they're doing with the treating doctor, to say, well, yeah, okay, you just had a mild, injury to your neck. This is what I got going on, and that's why I'm still having these problems. So, as well as employers. I mean, you know, again, I've had clients that have not that they should or probably have to, but depending on the relationship they have with their employers, I've had them take them into their supervisor and go, hey, this is why I'm leaving work early to go to my appointment. This is what I got going on. So
Exactly. And I'll tell you what, we won't touch into that today, but this procedure should be a standard procedure in work-related spine injuries, in any spinal injury, because
Yeah, I agree. And even the other thing I wanted to add, even my clients that have, then been diagnosed and gone on for the facet-mediated pain treatment through medial branch blocks and RFNs, it's still nice to have the CRMA because, well, every time that I've had a client that's been referred out for that has had a CRMA, it shows some excessive, motion, ligamentous injury at the level or levels of where the then pain specialist is doing the medial branch blocks and the RFNs. So again, it also helps all of us to refute, well, maybe this was pre-existing. Maybe they just had this there anyway, and so how are you going to prove that it was caused by this trauma? Well, aside from the fact they were asymptomatic. I mean, we all talk about that. Well, they were asymptomatic before, and now they're symptomatic. Okay, again, that's fine. But then we still have to fight the battle. Well, how do we know that? Maybe they were having symptoms and couldn't afford to go to the chiropractor, couldn't afford to go, didn't have insurance. Maybe they had this and then, now this injury happened, and so now they want to blame it all on that. Well, the CRMA helps, along with the other diagnostic and as well as clinical evaluations from the treating docs, to help refute all those, trying to prove the negative, so to speak.
Absolutely, absolutely. And we could do a whole program on pre-existing and what a dormant and active pre-existing condition is, and what a exacerbation and a aggravation is, and the differences in the terms.
Right.
Once you understand pre-existing, it becomes so easy, because it's an injury and it's consistent with what the mechanism delivers. So a person could take that fracture that I put up and say, well, how do you know it wasn't pre-existing? Well, I don't know.
Yeah.
He was walking around with this before. I don't know what to say. It would have been a major miracle. So when we start to really understand the conditions, and we're not going to spend a lot of time on pre-existing conditions, but it makes the pre-existing condition really easy to navigate. A lot of doctors have trouble with it, but they have trouble with it because they're not sure what the injury is in the first place. So it's kind of like the dog, patient comes in with a dog bite and you got an image of the dog bite. Most people are not going to say, well, they could have been bit by a dog before.
Right.
How do you know that's not pre-existing? So once you understand the injuries and the injury patterns that are consistent, plus remember, doctors that are listening, you're palpating these areas. You're saying intersegmentally there is inflammation here that's consistent with the injury. You're saying that there is a motor or a sensory loss that is consistent with the injury, that they didn't have before, that they weren't being treated before, that weren't active before. So it becomes a very uphill battle for anyone on the other side. And remember, on the other side has to prove it's the pre-existing condition and not the injury itself that's causing the condition. That's an uphill battle for anybody. So pre-existing conditions are not as difficult once you understand the language, doctors, and the language is not very hard, but not the topic for today's program.
The other thing, Dr. Cronk, I wanted to just emphasize too is, having the treating docs set this up early on in their treatment notes, I think is important, of saying, whether at the reevaluation, period, whether it's at 4 weeks or 6 weeks, when they're reevaluating, to put in there to say, at some point, and again, I'll leave it up to the docs as to when they should do it or whatever, but if they haven't done it right away, and because again, I just got a nice report from a treating chiropractor that said, a good percentage of my patients get better at 4 to 6 weeks or 6 to 12 weeks, and she put that right in her report, but this person hasn't. So now I'm concerned that we've got you know, some more significant ligamentous injury. We may have some instability, and you know, so and in her report, quoting from it, she says, there's no orthopedic test for whiplash, and it's hard to detect on plain film X-ray without proper training. And in this same situation, my client early on had gone to the emergency room and had X-rays, but they were looking for a fracture, and they weren't flexion extension X-rays.
Correct.
And so again, we hear that argument saying, well, why do you have to have these done again? Or why are you doing the flexion extension? Because they already had X-rays. And so now this is duplicative. It wasn't reasonable or necessary. Well, that's how you, in my opinion, that's how I refute it. That's how, if I was the treating doctor, I would say, well, you know, they weren't looking for that at the time. They were looking to see if there was a spinal fracture. And so they just did, you know, just a standard, you know, AP X-ray, no fracture, okay. But now in the clinical, you know, setting, here's what I'm thinking is what's going on, or here's what I perceive is going on. Here's why we need to then have these flexion extension, you know, X-rays, and then send it out for, as this doctor said, you know, somebody who has the proper training to be able to tell us what do we have going on here.
Exactly.
Objectively.
Exactly.
So.
Okay, I'll tell you what.
And in that, if I could just, and in that same, with that same client, she had 2 prior motor vehicle collisions. She healed up from both of them with very minimal treatment. One was, you know, 15 years ago. She thinks she went a month or 2. Another one was about 4 years before this accident, before the one I have with her now. And she went, you know, maybe, I think 3 to 4 months. Well, now this one comes along, and of course now she's not getting better, and she's concerned too, because she's been seeing the same treating chiropractor. So it's, well, what's going on? I got better on that first one. Okay, she was younger, and as we all know, you know, trauma to the spine, it you know, it accumulates, or it gets worse and worse. So now she's on number 3, but the question is, okay, it's been a year and a half now. Why is she still treating? Why is she still having problems? And, you know, she came to me late. It's not like I've been representing her for the last year and a half. She came to me a few months ago. And so now I'm having the treating chiropractor send her off for flexion extension, and then for the CRMA report. And I got to believe it's going to show something, because she had healed up before from her prior ones. So
Sure it will. Sure it will, Rick. And doctors out there that are listening, that's really you know, key. One of the things that's very interesting is once you do excessive motion testing and you have patients that have multiple accidents, the nice thing is you have a your first accident profile. Here's what the profile was with the first accident. You got a second accident. Now you can see what the profile is. Doctors, I'm telling you, from years of doing this, you will be utterly shocked at what you find. And you'll also be shocked at how easy it makes your life, because now you understand, and to get anyone else to understand, it's objectively right there. And it's so simple. Once you simply understand what it is and how to use it, it makes life so simple for you as a provider. So simple. Rick,
and Dr. Cronk, if I could just let me just jump in on that. I just went to a hearing with this client. She didn't have the flexion extension. In fact, she had them yesterday, but I went to a hearing first part of this week because she was gone, couldn't get in. Anyway, so we went to an arbitration hearing for her no fault benefit. We didn't have the benefit of the CRMA yet. But the one thing I got her to testify about, you know, because they were saying, oh, she'd been in these other 2 accidents and pre-existing and ongoing. She treated for neck pain before, blah, blah, blah. And of course, then I asked her, did the treating chiropractor on the first accident ever talk to you about having flexion extension X-rays and having to have a CRMA? No. Why not? Well, because I healed up and got better. How about the second one? No. Same response. I said, and now on the third one, yes, and of course we had the report from the treating chiropractor, and so I said, what's your understanding? She goes, well, my understanding is that the treating chiropractor is having me do this because I haven't gotten better. She's gotten better, but I haven't gotten to the point like I did from my prior 2 accident injuries and treating with this chiropractor, that there's got to be something more there. And so we now want to objectively find out what that is, and then they're going to regroup after that and find out, okay, depending on what the CRMA says, what should we be doing going forward to get this patient better, to get my client better?
Absolutely. I'm going to follow up with one question on that. I'm going to make a statement first. Doctors
Sure.
out there listening, one of the things that makes you significantly unique is when you're actually doing these services and you're explaining them properly, your elevated professionalism to the patient is significant. Because one of the things that patients always want to know is what's causing my problem. Why do I have this problem? So, Rick, and we'll conclude with this one. What's your experience been with your clients, with the doctors doing this testing and them feeling like they're, getting well taken care of because they're really identifying the actual injuries that they have?
Yeah, I mean, it's been significant. And again, I've had, the treating chiropractors that I've, sent out the information to from Spinal Kinetics, and I also, of course, copy in my client, and then they go in and both talk about it. I've yet to have one, whether it's the client and or the treating doc, come back to me saying, no, they don't need this, or I'm not going to do that. Every one of the doctors have said, well, that's a great idea. Probably should have done this before. And of course, I'm like, hey, that's okay. No problem. We're going to do it now, and let's we'll go from there. But the clients, my clients, obviously the doctor's patients, it's been huge to see this objectively, and for them to have an understanding. This is why I'm still having these problems. And now all this chatter I'm hearing from, again, friends, relatives, coworkers, whoever, of you need to find somebody different, you need to go somewhere different, it's all in your head. All of that then is now off the table. So
Beautiful. Beautiful. Rick, I really, really appreciate your time today. I know you got a busy schedule, and I appreciate the fact that you took the time, because it's hard sometimes to get an attorney to, where we put on a program and to be able to communicate very openly about, hey, this is my experience with this. That's all we ever ask doctors or attorneys or anyone that interfaces with us is, hey, what's your experience with it? And we have just loads of positive experience, but it's getting out there. At Spinal Kinetics, we want to make this a standardized procedure, doctors. It's a standardized procedure. It should be done immediately. Now, if there's pain or inflammation that's restricting the ability for the person to bend, you can't do it. If the pain and inflammation is there, but it allows the patient to actually bend forward and bend backwards, you can do the testing procedure. Pre-existing conditions and all these other things are very easy to resolve with this. If you are not a doctor that's using currently Spinal Kinetics and you want to use us, call in at 877-508-9729 or visit us at thespinalkinetics.com. If you need more information from us, you go to those 2 sources and we will help you. Rick, I really appreciate your time today. Thank you. Doctors, if you're in the Minnesota or you're on the border of Minnesota, you want to call, do I have your number? Yeah, you want to call 651-426, write down this number. If you are close, and I'd say an hour radius close, an hour and a half radius close, you want to have your patients, if you're going to refer out to somebody to represent your patient, you want somebody who understands their injuries. And when you find an attorney that does understand the injuries that you commonly treat, those are the attorneys that you want to be using. Rick, thank you so much today. Doctors, I appreciate it.
you're welcome.
Yep, I really appreciate your time, Rick, and we're going to sign off.
All right.
All right, thank you.
Yep, have a good day.
Yeah.